Um, oh, this is an easy one. Survey Monkey for today. Explain the difference between side effect and an adverse reaction. Who wants to tell me a side effect? Give me an example of a side effect.
Nausea,
Nausea. All right, give me another one.
Diarrhea.
Diarrhea. Yeah. Anybody else? Upset stomach, lack of
drowsiness.
drowsy. Oh, look at the poochie. So all kinds of things. Now, side effects. What's that mean? That means we can live with it, right? We're gonna put up with a little diarrhea or upset stomach because the benefits are outweighing it. Now, explain to me why, what an adverse reaction is.
It's something more serious than nausea and diarrhea that might need medical attention. Maybe
Uh-huh.
like you break out into hives and a rash and
So
that type of
would
thing.
if we had an adverse reaction to a medication, would we continue to take it?
No,
No.
No.
It
it's
means
not
that,
common.
correct. It means that it's not, the risks are not worth the benefit. Okay? That's what adverse. So it's real simple. So side effects mean, yeah, it's something we put up with because medicine's going to help us. But uh adverse means, nah, our body's not, it's not, it's not handling this. It's not going to be beneficial to us. The benefits are not outweighing, yeah, the problems that we're having. Okay. um since talking to y'all last time, tell me what y'all have done in labs, and I'm gonna mute and y'all go ahead. So I'm gonna suck down actually some coffees and y'all tell me what you've been doing.
We've been just continuing practicing the administration, like intramuscular, the intradermal.
Very
Um,
good.
we also took like prescription refill messages.
Yes, very good. Who's your instructor?
Miss Star.
Oh yeah, that's absolutely one of my favorites up there. Everybody's great, but Miss Star happens to be one of my favorites.
Yeah, she's
Um,
great.
yes, she is. Uh, so I'm glad y'all are working with her. Good. The refills and learning how to do that. That's important. So what else? Something else that I'd like to. How about those rights? Right route, right patient, right dose, right. Have y'all been looking that over since I posted that?
Yes, I've been looking it over. I've been trying to memorize it.
Hey, I love it. That's wonderful. Okay. Now, what about, let me share my screen with y'all real quick. There we go. Boom. Bam. Okay. So, what about this picture right here? Did y'all notice I uploaded you a picture and I added inhalation in buccal? Did y'all notice that? Nobody noticed it.
I saw the picture on Teams, but I didn't notice that you added.
Yeah, I added those for y'all, and then I put X's through the ones that y'all probably ain't never going to be doing, right? I made some changes to it. I like playing in paint. So that way, you we go over it, we make sure, you know, like you're never going to do this one. Unless you, hey, I say never, but I've had students go on and I got students that are doctors now. So never say never. I've got multiple students that are nurses. I got a couple of physician's assistants. Heck, I got one right now. She is in her first year of uh, her. Once you get your medical, you go on for anesthesia. She wants to be an anesthesiologist. So it's school upon school, upon school, upon some more school. So would she be doing this? Oh yeah. So I never say never. Okay. We're gonna go ahead and continue, and we're gonna keep moving on with lecture. But I'm going to be a little more lately. I've been just kind of blah, 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 and I haven't been asking y'all the questions. I'm going to start asking questions. So that means y'all going to have to stay on your toes and stay awake and dust off the memory. You know, participate with me here, okay? And I'm going to see if it'll let me. Yes, it will. Thank you very much. And we're gonna go to bam, boom. All right, all right, all right. All right, so this was everything we already talked about. Like I said, I added the buccally, I added the neb or inhalation to that as well. Okay, we talked about risk with the pregnancies, right? And we talked about that A is gonna be safe, right? This is what, if you're pregnant and you have to take a medicine, we really kind of wanted to fall in A or maybe B. But me personally, when I was pregnant, I wouldn't take anything past B. I was too scared. I didn't want to do anything. But some people have to. They have no choices because it's, you know, their life or the pregnancy, you know. We are going to learn a definition. And this is one I want you to write down and I want you to highlight and I want you to remember it forever. And it's called contraindication. And so basically it is when you know that a person cannot have a drug or a procedure or something because for them it would be harmful or life-threatening. Okay? So, and there's different. There is relative. This means a contraindication could occur if this patient is taking this medicine and now you need to give them this one. So you really have to monitor and be careful. And some examples of like that is when they're doing chemo or when they're doing certain, you know, radical procedures and, you know, to try to reverse conditions and stuff like that. The contraindication might be worth, you know, the risk might be worth the benefit. That's relative, okay? Absolute means no. No circumstances are we going to do this. This means that, yeah, we know when, if this patient gets this, it's going to probably result in their demise. They will die from it, or they will be injured beyond, you know, anything of coming back to a normal, you know, existence, life, and healthy being. So contraindication is a very important word, okay? So I love giving y'all examples. Examples are helpful. So I am anaphylactically allergic to sulfa drugs. So one of the things on my patient files and in my pharmacy says contraindications, sulfa-based drugs. So the doctor, the pharmacist, everybody knows, whoa, don't prescribe her this, it's gonna kill her, right? So there are so many variants to this because sometimes people have contraindications that are what we would term, we'll get to it, we would term this as something called idiosyncratic. And we'll get to the word. I don't know how to spell it. But idiosyncratic means that it's very uncommon. We only see this reaction maybe in just that patient, maybe in just a handful out of thousands. So it's very, very peculiar and particular to that one person, okay? And that does happen. Now, mine is an absolute contraindication that is very common. How many times have you heard somebody say, I'm allergic to penicillin, I'm allergic to sulfa, right? Or they're allergic to bees or nuts. So there's all kinds of, right? So those contraindications are kind of common, but there are some people who have very strange allergies and reactions to things that the rest of the world just doesn't have an issue with, okay? I will give you a great example. And this is thinking about it outside of the scope of pharmaceuticals. Has anyone ever heard about the family? Think they've got 2 or 3 little girls, and their little girl, they can't go in the sun. Has anybody ever heard about them?
No.
No.
They have a genetic disorder that they're kind of like literally like a vampire in the stories. This sun begins to burn their skin and they blister. And so sun would be a contraindication for them. How strange is that? How weird is that? We don't think of that as something. So, but it is an actual thing. I watched an entire documentary on them, and basically they live a nightlife. Their parents are amazing. They've made their basement into this gigantic playground. And so, I mean, and then they still take their kids out to the playground and to things like that, but they do it at night. And everybody in the community just understands that these girls, they've got it. They can't be into the sun. And there's odd things like that. But that contraindication would, believe it or not, and if you take it and make that a very pliable definition, that would be a contraindication. Does it make sense? And we need to think about everything by the risk. Does the risk, are they stronger than the benefits? Okay. So when we think about a breastfeeding mother, everybody knows whatever you are putting in your body, and if you're breastfeeding, your baby's getting, correct? So we have to think about when we're going to give a medication to a mother who is breastfeeding, we not only think about the mom, but we got to think about the baby, okay? The age, the size, the absorption rate, and all that kinds of things. How many of y'all have ever been asked, are you pregnant? Is there any chance that you're pregnant? Are you breastfeeding? Probably all of y'all.
Yeah.
Yeah, that's really common. And I'm going to give you once again an example that from me. My daughter, I was born cesarean, and she was perfectly healthy. 9 pounds, 10 ounces, big old baby, perfect. But I had a C-section, and then like the day I was ready to go home, they removed the little drip bag, and I ended up with a post-surgical infection. So I got to go home with her the first night, and she slept through the night. She was so big. But I woke up the next morning, and we were breastfeeding, everything was going great. But I started feeling hot and sick, like I didn't feel well. And I called my doctor. My doctor's like, I took my temperature, it was like 102. He's like, you got to come back in. I got to see you. They immediately admitted me. Come to find out, I had a post-surgical infection, and they had to give me a medication, an antibiotic called gentamicin. Gentamicin is a very strong antibiotic. And guess what one of the side effects of gentamicin is? Hearing loss in infants. So I was forced with, keep this infection because I'm allergic to sulfur and penicillin, so gentamicin was, or keep the infection, possibly, sick and die, or stop breastfeeding my baby. So I had to outweigh the risk. So that was, one of them things, because I didn't want to take a chance of, it causing her any type of auditory damage. So there are all kinds of things and considerations that we think of when we're thinking about drugs and their interactions in the body, not sometimes just the patient, but the baby or the fetus, or even when we start thinking about certain psychological drugs, that reaction, how that patient's are going to respond to the people around them. So there's a lot of things with drugs. Okay. Really quick, everybody tell me what, go around and tell me, what was the last thing that you had prescribed to you? Anybody? Nobody. Birth control, antibiotic, cough medicine, something for ADHD, anything. An EpiPen. Nobody's had any prescriptions.
I have heart
Recently,
medicine.
You take off. Okay, very good. A heart medicine drive you. And the doctor, when you go to see your doctor, how confident would you say that you have complete confidence and that this doctor, and that you trust this doctor, and they are going to write the medication, give you the right medication, it's going to be the right dose, and it's going to benefit you and be of aid to you? You confident with that?
Yeah.
Yeah. And how
Mhm.
and what important is it to you that you have that confidence between you and your doctor?
100%.
Oh, yeah, I can imagine. So we think about that, but something that we don't think about, and we don't really take it into consideration often, is that medication errors occur 1 in every 5 doses at a hospital. That's terrifying. Now, maybe it was minor. Maybe it was something that was something so small it's not going to make a difference. Um, Maybe it was something that cost that patient their life. 1 error occurs per patient per day in a hospital. Can you imagine that? And then 1.3 million people are injured, and approximately 7,000 deaths a year occur because of medication errors. And it says drug-related morbidity and mortality is an estimated basically $177 billion for the US. So now I got everybody straight. I ain't ever going back to the hospital. They're going to make a mistake, right? Well, this is facts. And this is why, even though we're not going to most likely be working in a hospital type setting, do you think that medication errors occur in doctors' offices? Yeah,
yes.
No.
they do. Oh, they do. They do. And I have once again, I have a real life example for you. I had a student, and she was a wonderful student. She just great. She got put, and I don't know if y'all know about Texas. If y'all think allergies are bad here in Florida, allergies are like on a whole nother level in Texas. So they're bad, they're pretty bad. So she got put at an allergist. And this doctor, well, when I tell you saw patients, they saw about 35 to 40 patients a day. And she had been working for this allergist, loved her job, loved what she was doing. And she gave lots of allergy shots, did lots of skin tests, and blah, blah, blah. And so one day, she was extremely busy, swamped. One of the other inmates didn't come in. And they had a patient that the allergy testing, and they knew what the person was allergic to, and they were trying to get them to build immunity. So they go in, and what they do is they give the drug, or the pharmacist or whatever, will make out a set of doses that the patient comes in and gets over time. One dose is, let's say, 0.5 of that allergic substance. And then the next dose is, 0.10, and then up, and then up, and then up, right? So that eventually what we hope is that their body will be ready to whatever they're allergic to, right? So she had a patient that came in. She was super, 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 super busy. She grabbed out, let's say, Mr. Jones's pre-thing, opened the thing, grabbed what she thought was the first dose, and went in there, gave it to him, had him stay for, their office was a 15-minute to make sure there's no reaction. There was no reaction, sent him home. Day started slowing down. She went back. She realized she had given him the very last dose. That literally could have put him into anaphylactic shock and killed him. And her first thing she did was call me. I said, don't call me. You need to go talk to the doctor immediately. And she's like, I already called the patient. I was like, okay, what did you say? I just asked him how he was doing and just checking up on him. I said, what did he say? She said, he said he was doing fine and hadn't had any problems. I said, that's very good. I said, now get off the phone with me and go do what you're supposed to be doing. And she did. And she went to the doctor and she told the doctor what happened. What saved her is this man was about 420. He's a big boy. And fortunately, because of his size, he did not have the reactions that somebody else who would have been smaller would have probably had. So, but that error occurred and it cost her job. And it unfortunately put her on a suspension with her certification. Errors occur. Guys, there was an error in somewhere up north, and I use this all the time. An MA had a set of twins that she was given their 6, 8 month, whatever injections to. And one of the mom or the caregiver or somebody took one of the babies to the bathroom to change a diaper. And she thought it was the other baby. It gave both babies both sets of vaccines on accident. No lie. So this is what I'm telling you, that you have to be cautious and you have to be on your toes, that and everything. When we talk about those rights, right patient, right dose. So what she should have done is walked in, maybe they had baby Michaela and baby Mariah. Now she should have walked in and said, all right, is Mariah ready for checking the chart, asking the parent, oh no, Mariah's in there getting changed. That would have, right there, that would have prevented the injury that occurred. Okay? So
always identify the patient.
always, always. And if you're unsure, don't do it. Okay? If you think like I said, that's why we don't set medicines down. This is why we don't do it. If you're unsure about something, it's better to be safe than sorry. I had a rule as a paramedic, and I taught my paramedic students. I can always put a drug in a patient, but I can't take it out. So I would always, and that's more of a more advanced, if y'all move on further. But one of the things that you need to understand is, yeah, if you put too much in, it may be, that's it. So always err on the side of caution, guys, always. That because this is important, we're going to start talking about writing prescriptions. And you're like, well, I ain't got to worry about that. I ain't no doctor. I got news for you. You'll probably, once you get in the rhythm of things, if the doctor you're working for, if they still write out paper prescriptions, you'll probably be writing out the prescription and the doctor will be signing it. And everybody's like, what? Yeah, that's not uncommon, especially for the medications that are like a constant reoccurring thing that the patient has to come in and pick up. That's just something that a lot of MAs do. So there are 6 parts to a prescription. I think this is one of your SurveyMonkey questions, is it not? I think it's tomorrow's or the next day's. So what are the parts of the prescription? The name of the drug, the dose, the route, the frequency, the amount, and the refills. All prescriptions have this. Now, do some prescriptions have more information? Absolutely. Okay. And of course, all of them have name and patient verifying information. Some have addresses, some have date of birth, things like that, right? But all of them need to have this. So I want you, if you're taking notes, take this. If you are coming back and going to take notes, please make sure you write this down. These are the first 6 parts to writing prescriptions. Okay, and I know y'all said Miss Star worked with y'all and y'all did prescription refills and stuff like that. Guess what? When you're doing a prescription refill, what do you, when Miss Jones calls and you're listening to her message and maybe it sounded a little unclear on the recording and you couldn't understand it and you thought she said something, what are you going to do? What would be your, what you as an MA, what would you do if you weren't certain what she said?
I would call her back.
Exactly. You're going to call her back. Hey, Miss Jones, you know what? I think we had a bad connection. Could you go ahead and tell me again, real quick, what medication you were needing? Uh-huh. All right. And it's this dose. Okay. And you take it by mouth. And how many times a day do you take it? All right. Okay. Very good. All right. Thank you. I just wanted to check. Checking. Making sure. All right. So that's something else. That, because a lot of the times with them phone call refills, it's a ton of voice messages, and you have to sit there and write down all of the voice, especially overnight and stuff like that. So you have to be precise in what you're doing. Now, are you, after you take these messages, are you going to pull that patient's chart up and verify?
Yes.
Yeah, absolutely. And then, of course, the doctor has to approve, you know, all refills and medications and stuff like that. But we would have everything ready for the doctor, okay? We are also going to understand other terms as far as prescriptions, okay? There are words here that we probably, pardon me, have not heard, like superscription. Ooh, sounds fancy. Superscription is that part of the prescription. What it usually contains the Latin or the recipe or comments. It can also be the part that contains the patient's name, date of birth, the prescription date, that kind. Okay, that's what we would superscription. All right. Now, the inscription is usually below, and it's the part of the prescription that contains the name and the quantities of the drug. This is the, I guess you'd say like the meat and the potatoes of the prescription. And then we have a subscription. Now that's below that, and that's basically any notes to the pharmacist. Hey, add cherry flavoring, or put this in a time-release capsule, or something like that, okay? And then we have Cigna, and this is the part that is the instruction to the patient. Take 2 pills by mouth twice a day for 14 days. So that's the Cigna, okay? And that's where a lot of your abbreviations are going to come into play, okay? And then last is you're usually going to have the physician info, like their name, their address, their phone number, and DEA, okay? If it's a controlled substance, it has to have the DEA number. And then the number of refills. Now, sometimes this is written in 1, sometimes it's something that's circled, sometimes it's 0. I mean, how many times can this patient get this medication from the pharmacy without having to go back to the doctor? And then there is a line that's called DAW. And DAW stands for dispense as written. And if it says dispense as written, this usually means that they want this exactly. So if the doctor puts a brand name drug, signs on this portion and hits the for DAW and does not check the box or allow that says allow for substitutes, this means that if when you take it to the pharmacy, and some of y'all might experience this, you take it to the pharmacist and they're like, oh, it's $575. What? Well, the generic's $4. Well, why aren't you giving me the generic? Because the doctors didn't check the generic, or they wrote dispense as written. So sometimes you can call back and have them call the doctor and have a generic. But this is a very important thing to understand when, and you might have to explain to your patient, this is how the doctor wants, okay? But like I said, if the patient has a real issue with that, that's something that they can take up with the doctor themselves. So let's take a look at it. Hopefully, how's that? Can y'all see that?
Yes.
Okay. So it's a little grainy, but what we're looking here is a prescription. So this is the superscription. Remember the Latin, because this is basically it means recipe. Okay, and then also this is the part that has all the patient's information. Now this DEA number is way up here, and this prescriber information's up here. Is it always going to be in the order that for every single type? Nah, some of them are different. Okay, this is vital, the date that the prescription was written, because some medications are only good for 10 days after they've been written, or 30 days after they've been written, okay? And when we're talking pediatric, there'll usually be a place that says the patient's weight. And we've already talked about why that's so important, okay? Next, our subscription. Remember, this is the instruction to the pharmacist. And so he's gotten, it's really hard to tell. It looks like phenobarbital, 0.075. And this looks like simethicone, and I'm having trouble making that out. And then magnesium carbonate. And then he's got some type of thing, okay? And this is telling the patient, okay, I'm something about capsules, BID, so that's twice, and at HS, at bedtime, so something about bedtime. So, right, HS is bedtime? Yeah, I believe so. Somebody correct me if I'm wrong. Refill, and then this is saying special instruction. How many times? Now, he didn't put anything, so the pharmacist is automatically going to assume it's 0. But a good doctor would put a 0 with a line through it so that nobody can alter that. And then here's that dog dispense. Now, if he signs that right there, that means they have to give you the brand names. But usually there's leeway with that. Let's come over here and look at a different type, okay? So this is a label that we have. So we have the pharmacy phone number, we've got the date, we've got the Latin superscription, and then who's it going to, right? And then this one's so much easier to read. Take 1 capsule, this is to the patient. So that is our, right here, our I'm sorry, I'm totally brain dead. Our Cigna. So this right here would be our Cigna. Take 1 capsule by mouth, and they didn't even abbreviate it here. 3 times daily for 10 days until everything's taken. What's the drug? The drug is the amoxicillin, 500 milligrams capsules. Quantity, 30. Refills, no. Why? Because this is an antibiotic. Do we really want them getting refills on an antibiotic? No, because if they're still sick, they need to come in. So when we're looking at the medication, or that's the inscription, right? That's the medication and its dose. And then this is that date I was telling you. Don't use the drug past this date. That may not be on every bottle, every prescription, or something like that. That's it's going to be different for every type of medication. And most of them won't have this unless it's something that is time sensitive, or something maybe that you see special instructions on. And we're going to go through them too, like keep refrigerated, keep at room temperature, or shake well before use, those kind of things. And then, of course, the date, once again, that it was prescribed. Now, I know that this can look very intimidating at first. Did y'all go through this in lab? Did you look at prescriptions?
No, we haven't looked at them.
Okay. I'm gonna be uploading several to Teams, and what I'd like you to do is I would like you to look at them and then label them. Draw out next to it and tell me what each part is. That helps you get the hang of what each section's called. And you can see me. I still, it's been so long since I've done it that I got to go back and forth and double check. What's the signal? What's the subs? You know. So get familiar. Get in the habit of practicing with a few of these. The other thing that I want you to practice is I'm just going to give you a bunch of directions. So a bunch of different Cigna. And I want you to abbreviate them properly. So it's going to be something like patient is to be given um, tetracycline, 250 milligrams, and the patients to take 1 capsule by mouth after meals 3 times a day until finished. So I want you to put this and get it to where that it is in prescription lingo, okay? So like example, by mouth. Anybody know what that abbreviation is? PO, by mouth, okay? 3 times a day, what is that?
TID.
Yes, very good. TID. All right, so we need to, those abbreviations that I sent to y'all, please be studying them. I have Cahoots to help you practice and study with them, make it kind of fun. Go through there, check them out. The other thing is, I want you to be able to start feeling comfortable writing them and understanding what they mean. Now, I am going to be giving you a quiz on those abbreviations, and it's going to be done via SurveyMonkey. So that's probably going to be next week. So start studying those abbreviations, okay? It's going to be a necessity. All right. Now let's go to 2020. Most everything is going to be digital nowadays, and we've been talking a lot about e-prescriptions and how the doctors can basically, with deep controlled substances, put their thumbprint on their little device and send away controlled substances straight to the pharmacy. And what does that help prevent? If they're able to send a controlled substance straight to the pharmacy, what does that help keep from happening to that prescription? It being altered, yeah, it being changed in any way, or it being duplicated, right? So when this is an example for our EHR, so we open up our patient's chart, and we have Ralph Farrow. And if he's 57, this is his birthday, address, okay? So the first is going to be brand name. The doctor specifically wants him to have Bactroban 2% ointment, and that 2, okay? So the prescriber is Dr. Gentry, and no, he's saying no DAW, so that means he could get a generic if he wanted. The quantity, I can barely read that, yeah. The quantity is 22.5 grams. Refill, 0. And what is the patient sig? Apply TID, we just said that, 3 times a day, right? What is PRN?
As needed.
Very good. External, so on this, right, on the skin for 14 days. And then the date, and then when it expires. And then this is it right here. And so that's everything he's typed up, and this is what it looks like when it's sent over. So patient's name, so forth, quantity, 22.5 grams, Bactroban 2% ointment, and apply 3 times a day as needed externally for 14 days. Does it have to be brand? No. Refills? No. Okay? And I know this seems like it's a lot to take in, but how's everybody doing so far? Hanging in there? Hanging in there? Okay, 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 okay. That is it for this portion of pharmacology. You're like, oh, we're done with pharma. You ain't done. I got a bunch more sections, but this is a big chunk of it that we've gone through, and we're going to continue to build on it. Pardon me, and we're going to continue to add to this knowledge. So what I have to advise from y'all is, if you are uncertain about bioequivalent or contraindication or generic versus brand versus, what does the word proprietary mean, or how long does a pharmaceutical company have the patent for, at any of those, go back and review. You need to have this information down. And then once you get that chunk down, I want you to start really hammering in on the abbreviations and learning the drugs. That, guys, I cannot stress to you how important it is that you have, and I'm going to go back one more time real quick. Hold on. These classifications right here. Remember this? And this is in your book. I want you to be able to tell me what an analgesic is, what an antacid, an antiarrhythmic, cardiogenic, bronchodilator. You should be able to start giving me, at least telling me what the drug does. Okay? So, saying that, I know I told you I was going to be quizzing you on abbreviations. Be expecting a quiz as well on classifications. Now, y'all should be doing your drug card projects, because when's that due? Saturday. And like I said, if anybody runs into trouble and if you need a little time, let me know, okay? But you should be picking up that information as you're doing your project, right? So don't be surprised come next week if you see a quiz or two, okay? But I've given everybody a warning, so nobody freak out, run around crazy or anything. Now, tomorrow is lab, and I really want to make sure that y'all understand, everybody's supposed to be back in lab, right? Everybody's supposed to be back in lab. And if for some reason you were unable to attend lab, we need to talk about that one-on-one private, okay? So get with me, okay? And we need to go over and discuss that. But besides that, does anybody have any questions? Anything they'd like to add, ask, complain?
Those prescription labels that you were gonna post up, is that gonna be like an assignment thing that we have to get back to you?
Yeah, it'll be something that it'll be like just like a daily kind of thing. Sorry, my hair. Yeah, it's
like
not going to be
exercise.
Yeah, it's no, it's something I'll just put out there, and you can get it back to me. Now it says I'm not going to put like time restraints or something on it, but it is something that I want you to do, okay? Because it's going to benefit you. It's going to make things easier, okay? I like to try to be flexible and kind of go with the flow, because some of y'all really need that flexibility with everything going on, jobs, work, school, and you know what I'm saying? So, but I don't do that. But I do, and I am telling you, start studying them abbreviations. So I'm gonna post you a few things that you have time to work on, but I'm also gonna send you a link to my abbreviation Kahoot. And I'm telling you, I don't wink very well, but studying that will help you quite a lot, okay? It's going to be something that'll be very beneficial to you breezing through this quiz. See what I mean? Catch my drift?
And page 1319 in the Pearson book, it has a table of commonly used abbreviations also.
It sure does. It sure does. And I have picked out like some of the most common ones, and that's what's on my Kahoot. And if I was you, those would be the ones I would study. All right. And those classifications, you can probably bet whatever you have on your drug project card, those classes, that's what you're going to see on your quiz. So like I said, if you're doing your drug cards, you should be good with that. Okay? Any other questions?
No.
All right. Y'all have a wonderful day. Please make sure you attend lab. And if you have not done your Survey Monkey, please do so. Okay? Bye, guys. Stay safe.
Thank you.
Have a great day.
Oh,
Have a good afternoon.
make sure you hang up too.
Okay.
Bye-bye.
Bye.